Good evening. Thank you very much, Arthur, for this very kind introduction. I will start with the talk right away, and I will have after sort of, it's 4 parts, and after each part I will have a couple of questions, and we will have time enough at the end as well to answer more questions. And I will hang around a little bit after, so if anyone wants to ask more, you're more than welcome to do that informally as well. Just before we start with the talk, I just wanted to introduce quickly our Royal Free Ophthalmology department. We are a little bit in a sort of a hub and spoke model. So we have the Royal Free in the center here. We are 13 ophthalmologists, consultants, and lots of support staff. We have quite a lot of specialist doctors, associate specialist doctors, and we have as well trainees. And we look after Barnet, and we look after Edgware, and the Whittington is supplied doctors-wise from the Royal Free, and we have some doctors working at UCLH, and as well we have with all of them, we share sort of the on-calls and all the rota. So just to give you a bit an idea about the ophthalmology department. Now, what is the objectives tonight? Well, I thought I will explain to you what are the common causes of visual loss in the adult generation. I want to talk a bit about symptoms and who is at risk. I want to go through some clinical findings and treatment options. So I have put up a little picture here, and we will start to go through that. First part of the talk will be about glaucoma, which is actually a disease affecting the front part of the eye with the drainage channel and causing damage to the back of the eye, to the optic nerve. The second part of the talk will be about cataract. Now, cataract is your lens in the eye, which you can see here as a structure. The third part will be about age-related macular degeneration, which is a very important subject. And if I show you here where this faint E letter is, that is actually the area of your macula. That's the area you read with. The last part of the talk, and very much at my heart, because I'm as well the director of the Diabetic Retinal Screening Program in North London, and we have a stand here tonight, so the last part is about diabetic retinopathy. So, let's start off with glaucoma. I think from all 4 subjects, glaucoma is probably slightly the most difficult one to understand, so please bear with me if it is a bit tricky. So I want to explain to you what is glaucoma, who is at risk, what are the symptoms, and what are the clinical findings, and treatment. So, yes, what does glaucoma mean for my sight? What does it mean? Have a look at this picture. Normal vision. You can see these 2 boys there with their balls. So when I have glaucoma, how does it look like? You can see here the bottom photograph. What is interesting is the center is still there. The periphery is a bit blurry, but the center is not perfect either. So that is just, from the picture point of view, an idea what glaucoma does. And I have a few more simulation pictures further on, which I think are quite interesting. So what is it? Well, it's a complex eye disease. That's what it says in all the textbooks. It's affecting normally both eyes. It's an optic nerve damage, and it's causing visual field loss. And it's a silent disease with late symptoms, and that's a very, very important part. So if we have an eye here, cut open, this is your front part with the cornea, and this is your iris there. This is your lens, and then we have too much pressure inside the eye, and that causes the damage to the optic nerve. To make everything more complicated, there are different types of glaucoma. There are 4 major types. We will not go into all 4, but I will cover 2. The most important one is the primary open-angle glaucoma. This is 90% of all glaucoma disease. 1 in 100 over 40 is affected. That means 480,000 people in the UK. It counts for 12% of all blind registration in the UK. We have the second important group is the acute angle closure glaucoma. And although it's not that common, it's a 1 in 1,000, but it is a blinding disease, acutely blinding. So that's why I want to talk a little bit as well about that. And then we have secondary glaucoma, which is caused by other diseases. And you have children, babies who are born with glaucoma. I will not cover number 3 and 4, just the top 2 ones. So if we have the primary open-angle glaucoma, the one which affects 90% of all glaucoma cases, what happens is we have a reduced drainage. So if you look at a model of the eye again, now this is this vertical cut, the eye produces fluid all the time, 24 hours a day. You have fluid production inside the eye, which is produced from this part here. It's named the ciliary body. So fluid is produced, it floats into the back, and it floats through the pupil into the front. It gets drained in the front part of the eye. So increased pressure inside the eye, it's a bit like the blood pressure. You have a pressure in the eye. So increased intraocular pressure, that's what really mainly glaucoma is about. And an increased pressure, it pushes and presses on the optic nerve, and it damages the optic nerve mechanically, and we assume as well because of restricted blood flow. When you press on something, you restrict the blood flow, and that damages. So if you get damaged optic nerve, you get disc cupping. So the optic disc bows backwards, and the optic disc is responsible for your field of vision. So obviously then you have damage to the optic nerve, you have damage to your field of vision. So what are the risk factors? Well, unfortunately, increasing age. So all of us are at risk. A family history, it's not directly, it doesn't mean that when one of your relatives has glaucoma that you definitely get it, but you have a much higher risk. Race as well, it's more common in the black population. And short-sightedness, I put that in sort of semi-print. In some books it says short-sightedness, myopia, can cause more likely glaucoma, as can diabetes, but that is not that well established. It's really age and family history. So, what are the symptoms in primary open-angle glaucoma? How do you know if you have it? Well, that's the trouble. There is none in early stages. There are no symptoms. In late stages, then, when your visual field has been severely affected, sometimes it can be noticed. So, how does the visual field loss present? You think probably it's quite easy. Visual field loss, get a couple of black patches, no trouble, I realize that, see the optician. Well, it's not that easy because the early changes are not obvious. First of all, you have 2 eyes. One eye will cover for the losses in your other eye, so you might not realize. The other thing is the blanks are filled in by the brain. I have an example how that happens. And it does not present as black spots, unfortunately. So, this is an interesting photograph. It's a work done by a lady from Holland who has created these picture series. I want you to have a look at it. Just imagine your right eye on this photograph has been sort of damaged. You have no vision in the right eye, so you're looking with your left eye. This, in the bottom here, is a visual field blended in there. It's a normal visual field. The black spot is your optic nerve, which is always a blind spot. So you're looking with your left eye. So these children are, left eye, they are nasally towards your nasal side. They are coming here, running into the street, behind a wall. You are driving in a car along the road. Look what happens. You have a visual field defect, nasally, so on the lower side, where often glaucoma starts, and this is your fixation point. Look what happened to the children. They are gone. The only thing you can see is the head there, and you can see the head of the car. That's the midline. That's your line there. And look what is even worse. the sidewalk has been filled in. So it's as if there's nobody there. So the brain has filled in the empty patches, which you didn't see. Go next step. You have more visual field damage. That's a sort of a more advanced glaucoma visual field. You just have the center still working. Now look what happened is, children entirely gone, that car standing here gone, the other car parked here gone, and all what you see is the road. And everything seems fine, because you can see the curvature there, you can see that, you don't think there's any problem with your eyesight. And this is just to repeat again, to summarize it, children there, gone here, even the car, and this car is all gone there. So this is just to give you an idea what glaucoma can do to you and how you just don't realize it till it is very advanced. So what are the basic investigations? First of all, if you go to the optician, they generally check for glaucoma. So they will do a couple of checks. They will check the pressure of your eye. And as we just heard, that 90% of the glaucoma is a sort of an open-angle glaucoma, and the majority of them is patients who have a high pressure. So that is already giving some sort of hint. And then often the opticians will do a visual field test if the pressure is high. If there's any suspicion of glaucoma, the optician will refer you via the GP to a hospital eye service. And then we will do a couple of more tests, like we measure the thickness of the cornea, we look in the angle of the eye, and we check as well with picture of the optic nerve. So tests for glaucoma, just that you're not too frightened if you get referred to the hospital, we measure the corneal thickness, it's not painful. We have a look at the pressure inside the eye with a little device which touches your cornea, but again it doesn't hurt because you get some drops for it, so you don't feel any pain. This is a very important machinery here, it checks your visual field. And then this is a machine which just checks your nerve function, the optic nerve in the back. And this is a little lens we put on to look into the angle to see is there any blockage of the drainage. I just show you 4 pictures how the optic nerve sort of progresses in glaucoma. This is an optic nerve picture of a normal optic nerve. You can see that the center has a little dimple there, so it's a little cup there. What happens in glaucoma, and this part here is the nerve fibers. And you will hear people talking about a cup-disc ratio. This means the big cup and the little sort of center which has been held out. Now this picture, so it didn't come entirely up there, but this is another photograph of an optic nerve. And can you see the cup is much more bigger here, so some of the nerve fibers have disappeared already. And this is a very typical sign. You can see a little bleeding on the optic nerve. That's a sign that something is wrong. There might be glaucoma. Now, in case you have diabetic eye screening, sometimes you will find a report where it says a small bleed on the optic nerve. We refer you for further tests just to check if there is any glaucoma. It doesn't mean when you have this bleeding you have 100% glaucoma, but it's a risk there. So that's why it should be checked. And this is a sort of an end-stage glaucoma. You can see the nice pinkish nerve fibers are all gone. How do we treat glaucoma? Well, it's mainly done with eye drops. That's the real thing. If you detect it early, you get drops which reduce your pressure in the eye, and then you can, go on like normally, and it often progresses very, very slowly or even stays stable. So early treatment is great because you can maintain normally your sight. But you have to take those drops long term, and I assure you that's the main problem, because it's very boring to have to put eye drops in every single day for something where you have no pain, no discomfort, and you even don't realize the field losses. So that's the most important part, is the compliance with the drops. I just put a couple of drops down there, which there are, just in case any of you is a glaucoma patient. So you have ones which you take once a day, ones which you take twice a day, and then some mixed ones. But I will not go in very long into those. Then we have as well, for some patients which can't be controlled by drops, we have an operation where we create an artificial drainage in the eye so that some of the pressure gets released and it drains underneath the conjunctiva. You can see a little bubble there, and we have opened up here a little part from the iris, so the fluid drains underneath there. That's what we have to do sometimes. It's named a trabeculectomy, and then there are a couple of other operations for it. So that was the open-angle glaucoma. Now, if we go to the other one, which is not that frequent, but very important because it's an emergency situation for the eye, it's the acute angle closure glaucoma. What happens there is you have a sudden increase of the eye pressure, and it's generally in one eye, and it's caused by partial or complete closure of this drainage angle. So suddenly it closes, pressure rises up, and that gives a lot of pain. Risks are people with relatively small eyes. So if you have, there are people who are short-sighted and people who are long-sighted. If you are long-sighted, it really means you have the slightly sort of thicker glasses. You need glasses for reading all the time. And these are the people who have smaller eyes. The short-sighted people have actually very long eyes. There's more space. But for the small eyes, they are at risk for narrow-angle glaucoma. And as well, if your pupil is dilated or in dim illumination, that's a risk. Just very briefly, look at the mechanism. That is the angle. So this is the front part of the cornea. You have a deep angle there, and that's your iris, and that's the lens. Fluid produced here, which I explained to you, which dribbles through here. Now, you have a small eye, not much space, and the lens increases with age. It's like an onion. It gets an extra layer all the time. So your natural lens gets bigger and bigger. So when you get older, your lens is a bigger size. And if you start off with little space, you even have less space there. So what happens then? Fluid gets produced, but it can't escape there. There's not much space. The iris is blocking it. So then it pushes the iris forward, and it blocks off your drainage, because the drainage is here. So what we do is later, I show you a picture of that. We put a little hole in here, so the fluid doesn't have to go through this pathway. It can escape just through that. So symptoms are blurred vision, suddenly blurred vision in the eye, rainbow colors around light sources, and frontal headache, severe pain over one side, often with nausea and vomiting. You really feel unwell with that. And often similar episodes can be aborted by sleep, because when you sleep, your pupil constricts, and then there's a little bit more space for the drainage again, and then it goes. But if you have rainbow colors around light sources, it's a bit like for the swimmers under you, when you sort of have no swimming goggles and the cornea gets a bit swollen after swimming because of the water. You get these rainbow colors around light sources. It's a bit like that. But of course, you get severe pain with it as well. So if you have any of these, you need to see somebody urgently. Oops, sorry, I want to go forward. Yes. So what we do is, we can check a visual acuity, the sight will be reduced, your eye will be red, you have often a fixed mid-dilated pupil, the eye is quite shallow, and you have a hazy cornea, and the eyeball will feel very, very hard. It's rock hard on that side. And that's a sort of a picture, mid-sized dilated pupil. So, from the treatment, I will not go in all the details, I just put that down for people who might be interested. We give tablets or IV injection to bring the pressure down as an emergency. The pressure can raise, the normal pressure in the eye is anything between 10 and 25. These people can have pressure of 60 or 70. So it's very painful. We need to get the pressure down immediately, because the optic nerve otherwise gets like an infarct, will pack in quite quickly. So we give IV injections, we give topical treatment, we have to do the little treatment I explained to you. That's a laser treatment where we open up the iris so that there is an extra escape route. Okay, so this was the glaucoma side of it, and I just thought I'd interrupt for a couple of minutes for you to ask questions, and as I said, we have then at the end some, but just any questions about the glaucoma part? Yes?
About the thickness of the cornea, that
yes.
Can vary, can't it?
Yes.
And people, I understand that people with a thin cornea can be more at risk.
Yes, let me explain.
I don't understand the mechanism.
Okay, the lady is asking about the pachymetry, which is measuring the thickness of the cornea. For what do we need that? There is a standard sort of average size of the corneal thickness, which is around 500 microns. Now, if you have a very thin cornea, the way we measure the pressure, because we indent the cornea when we measure the pressure, when you have a very thick cornea, you need very little power to indent. So you get false positive low pressures. So the pressure in the eye might be quite high, but because you have such a thin cornea, you can so easily compress it. You get a very low reading. So you say to the patient, your pressure is 10 or 12 or 15, but in reality, the pressure is actually much higher, and the patient can get problems with their optic nerve. So therefore, as a standard, and it's a part of the NICE guidelines, everybody who is assessed for glaucoma will have a measurement of the corneal thickness so that we know, is the patient in the normal range or do they have a very thin cornea? And as well, the people with a thick cornea often have been classified as glaucoma patients, and actually they just have a very thick cornea where we get a false positive high pressure. That's why. Any other questions? Okay. Well, before you fall asleep, then I will have to ask questions in a bit. But let's go on to the cataract. As I said, I think the glaucoma was more sort of difficult to understand, but let's go off with the cataract. Now, with the cataract, I go for definition, we'll look at the symptoms, clinical findings, and we talk a little bit about the cataract operation. So, if you have our little two boys again with their ball, normal vision, light goes normally through here. You can see the lens is right there and it's clear. And the light beam goes nicely there, focusing in the back. This is what you see with a cataract. Overall, your vision is blurred and it's very difficult in sunlight. Why is it difficult in sunlight? Because your lens is no longer clear, it is cloudy and it scatters the light. It's as if you look through some kind of funny lens which is dirty. It scatters the light. So that's the problem. So that's why the vision is blurred. So clouding of the lens, that causes the reduction of sight. It's most common. The most common cause is age. So it's not much one can do about it. Other risk factors, though, are diabetes, causes more earlier cataract development. You can get some medications, for example, asthmatic patients who are on steroids, or if you suffer from rheumatoid arthritis and are on steroids, that can bring up a cataract at an earlier stage. You can have trauma, which can trouble you with trauma issues and damage the lens, and you can have chronic eye inflammation. And, well, smoking as well makes it a bit worse, and sunlight. So if you are a lot outdoors in very bright sunlight, that can progress a cataract. I gave you a couple of pictures here, just two examples. So this is what we name a nuclear cataract. So you have nicely here the iris, the cornea in front, and that beam is a slit lamp. It's an examination where we look into the eye, and you can see this brown part, that's the lens, and that should be clear. So that's a brown cataract, nuclear cataract. And everyone can see here, this is a white mature cataract. Now, vision here, you probably can still read sort of like 6:18, if that tells anybody, 6:24. So you can probably just opt for driving limits, but you can still see some extent, and you should be able to read still. With this one here, obviously, there's no counting fingers, is the most you can expect with a white one. So, when to treat a cataract? That's a very important question, and it will come up again because there is been some sort of talk about to restrict cataract operations to a certain level of reduced visual acuity. But it's not entirely there yet. So when shall we treat? In my opinion, and I think a lot of the ophthalmologists share that, it is when it affects your personal life. And it doesn't mean a specific visual acuity. It doesn't mean 6:12 or 6:18, if that means anything to you. It means when is your eyesight affecting your life, what you want to do. So if you have difficulty driving, or when you fall below driving vision, driving standard, which is, by the way, 6:12, if you have glare from lights at night, or other visual disturbances, that's a good point. Difficulties with daily tasks, can be work, reading, sports. If you play golf and you can't see the golf ball anymore, things like that. And that's a good enough argument. So if it impacts on your life, then it is a good point to go for a cataract operation. And of course as well if it reduces your independence. So how do we treat the cataract? Well, only surgery still in the moment. There is no wonder drug. Sometimes on the internet you find all kinds of stuff which helps you, like drops which will prevent the cataract development and all that stuff. In the moment, nothing on the market there. It's really still just surgery. And it's 90%, over 90% are done by phacoemulsification, complicated work. It just means you suck it out by ultrasound. The ultrasound destroys the lens, sucks it out. That's the way how most of the operations are done. And yes, it's here, laser-assisted phacoemulsification. And you might have seen some of the advertisement where it says, now you don't need the knife anymore, just the laser for your cataract operation. Well, I will tell you a little bit about how the laser is done, but it's not exactly the truth. In the past, we have had extracapsular and intracapsular. These were operations where we had much larger wounds and we removed the cataract that way. They are quite rarely performed nowadays. So what is involved in cataract surgery? It's actually one of the most frequent operations in the Western world. So it's a huge amount of people, most likely some of you have had it already. It's quite a safe procedure, but with every operation, complications and risks can occur. Anyone telling you there is an operation without any risks, don't see that person again, because it's not true. There is no operation without risk. Now, preparation for the operation. They need to measure, because we take that old lens out, so they need to measure the new lens which is going in. So that's one of the important parts preoperatively. And then the cataract operation is a day surgery procedure. You don't have to come into hospital for like days. It's done under local anesthetic in most of the cases, and it lasts about 20 to 30 minutes. And you get antibiotic eye drops and some anti-inflammatory eye drops for 3 to 4 weeks, and that's it. So I was thinking, shall I bring a cataract operation? And then somebody said, well, you don't know, some people might find it's a bit revolting seeing a cataract operation. And so I took pictures. So for the ones of you who wanted to see one, but if you go on YouTube, there are lots of them there and you can have a look there. So I just got some pictures there, some drawings which are from the internet. In any way, so phacoemulsification. So what we do is, we do a cut into the cornea. We need to get into the eye. Then, next step, we have to open up the lens bag, because the lens sits in a little bag. So we have to open that up roundly, and then when we have opened up the bag, this is the lens now, this brown stuff there, the white part is the bag. Then we go in with this phaco ultrasound device, suck out the lens, and then when the lens is sucked out and cleaned out, then we put a new lens in. And that's most of the time now, it's an injectable lens. It goes in a little injector and it's injected into that bag and it unfolds, and there it sits, your new lens there. So that's the new lens. Now, there are different types of lenses. The standard lens is a monofocal lens, meaning it can give you a focus in one area. So either the distance, or if you are very keen, a keen reader, and say, I don't care really about the distance so much, I want to be able to read in bed without glasses, then you would be a person who would like a lens which makes you actually short-sighted. So you can read without glasses, but for the distance you would need glasses. Then in the private sector, they offer as well multifocal lenses. So you'll say, oh God, again, something we can't get on the NHS. But, comes the but, the multifocal lenses work well for some people, but for a lot of people, they have quite a lot of drawback. Because if you have any other problems in your eyes, macular degeneration, diabetic changes, glaucoma, then you should not have a multifocal lens, because multifocal lenses take away some of your light going into the eye. So only people who have no problem like that should consider a multifocal lens. And then as well, you have to think, if you are a short-sighted person and you are very you like to have the perfect vision, you are not for multifocal lenses, because there will always be a slight blur. It will never be as crisp as it used to be. Just for you, just in case you think about it. But as I said, on the NHS, multifocal lenses are not available, but generally I think monofocal lenses are still the better option. And they have done last year a big survey in the Cataract and Refractive Journal, and they asked surgeons from the States, from Europe, ophthalmology surgeons, cataract surgeons, what would they go for? And actually the vast majority would have gone for a monofocal lens, but with monovision, one lens for the distance and one sort of for reading, but not for the multifocal lens, just for your information. Laser cataract surgery, here it is, very expensive. I know it's very much in the press. Lots of people, you know, get sort of these flyers in. It's quite expensive. What does it do differently? Well, actually, it cuts the holes, which I showed you with the knife, with the laser. So the hole, we still need a hole, we still need to get in the eye, but it's cut by the laser instead with the knife. The other thing is the lens, instead of entirely sucked out and split, it gets cut as well into smaller pieces. But again, you still need, for most of them, the phaco to suck it out. So it's not that much a difference, but it is very precise, because your opening of the little bag is exactly the way how you program it. So that's what people say, it's a more accurate procedure. Does it have less complications? It might have in future, but in the moment it doesn't. It has still the same amount of complications like a normal cataract operation. So you don't need to rush out and pay a lot of extra for the laser-assisted phacoemulsification, in my opinion. It's my opinion. Now, age-related macular degeneration, I should have forgot. Cataracts, questions? Yes, please.
As a watchmaker, if I had a cataract operation done, could I carry on working like before?
Yes, you can. You can very much so. I don't know what your refraction, for example, is in the moment, but if you are a bit short-sighted and you would like to maintain that slight short-sightedness, that you can flip your glasses up and then see a bit closer by, that can be accommodated for. One would just make you a little bit short-sighted again with the new lens, which we can perfectly well calculate, and then you would be pretty much like you are now with the glasses for the distance. Yes, please.
What happens when you have one eye which has a bad cataract and the other one just beginning?
Right, you can have theoretically the eye with the bad cataract operated right away, and then the other eye can be operated later. There's only one problem. If you are very long-sighted or very short-sighted, and you want the new eye, of course, being normal-sighted, then there is a big difference between the two eyes, and sometimes the brain can't accommodate for the big difference. Not with glasses, with contact lenses, yes. So two options. Option one is you go and have the contact lenses then on the eye which is not corrected. Option two is that you go and have the other eye, which is starting with the cataract, operated as well, so that both are matched, and then you have both done.
Because I've been told that sometimes you could see double if you have only one eye done.
When you have only one eye done and there is a big difference between your glasses, then you can give you double vision. That's why either you need a contact lens or you need the other eye done quite soon after to match the two eyes again. Yes, please.
What's the range of rate of growth once you sort of get the first hint that a cataract is coming?
All right. So
How quickly and how long can they take to reach a stage where most
yes.
people would want an operation?
Well, the progression of cataract is very different in every individual. So generally, if you have one of those nuclear brownish cataracts I showed you before, they might take years. If you have one which is more the steroid-induced one, where you have just the part in the back which is cloudy, those ones can develop in months. So there is a wide variety, and it's very much individually different how quickly they develop.
The lens is put in the eye when they do the operation.
Sorry?
You said you can put a lens into the eye.
Yes, every cataract operation has a new lens put in. Because we take the old lens out and we replace it by a little new plastic implant. One more question, yeah?
What is the new lens made of?
It's an acrylic material. It's a plastic material. Some of them are water, hydrophobic and hydrophilic acrylic lenses. So it's a plastic material. It's an artificial plastic material. In fact, the first ones were made out of plexiglass, and it's a funny story. It was actually a British ophthalmic surgeon who realized that in the Second World War, some of the fighter pilots had injuries with their plexiglass from the plane and had plexiglass pieces in the eye, and those plexiglass pieces were actually inert. They didn't cause any inflammation. So he thought if one makes a replacement inside the eye from that material, then it should be inert. It should not cause an inflammatory reaction. And so that was Mr. Ridley, and he developed the first lenses. It was an English ophthalmic surgeon. Okay.
I have different sites in each eye, so it would, if I have a cataract operation, it would have to be done quite closely together, wouldn't it? But they couldn't be done both at once.
Generally, it's very rare that we offer cataract operation, both of them at the same day. Some places do it, and but in the past there was always quite an objection. The reason was that although it's extremely rare to get an infection in the eye after the cataract operation, it still is a possibility. And there is just this fear that if you are one of the unlucky one, you would get an infection in both eyes, which would cause potential blindness. So most of the surgeons actually don't want to do both eyes at the same time, but one can agree with the patient to do it within, like, if you have very different eyes, one can do it within sort of 4 weeks, 6 weeks. That's not a problem. So, shall I continue? And if there are any more questions, then we can do some more at the end. Yep. Okay. Thank you. So, if I go to age-related, so please keep your question. I will have some time at the end. Age-related macular degeneration, part 3 of our talk. I hope you are still awake. And so, what's the definition? Symptoms, clinical picture, and what is the treatment? Again, our two boys, we know them now quite well. Macular degeneration affects the central part of your eye. Do you remember that picture with the E? That's the central part. So here we have a picture, something starting in the center. So the periphery is still a sort of clear, but wherever you look, you have the central blur. This is a more advanced disease, where then everything has gone down, but mainly in the center. It's as if this big fat blob is right away in the center of your vision. So, what is it? It's a degenerative retinal disease affecting the macula, and the macula is your central part of your eye responsible for your defined vision. Dry macular degeneration affects 80 to 90%. It's a shrinkage of your nerve fiber cells. And I talk a lot about the wet AMD, wet age-related macular degeneration, which is only 10 to 20% of the patients, but it counts 90% of the vision loss. So that's the nasty one you can get. Just have a picture here. So this is again the eye, this is your optic nerve, this is the front part, this is the macular area here, and you can see now a cut through those layers. So you have the nerve fiber layer here, and actually it comes, this is the sclera, so that's the white part, the outside bit, and this is a layer of blood vessels which is supporting the back photoreceptors in your eyes, and that's where the trouble is in these layers there. So this is the area of the photoreceptors, the supplying blood layer, and have a look there. That's the normal side. So that's the back of the eye, and that's how it should look. But now what happens? You get a thickening of this layer, debris is forming up there and collecting there, pushing the photoreceptors a little bit out of place, and that's how it looks in the picture. That's named drusen, and some of you might have had reports from ophthalmologists that you have some drusen, earliest stage of macular degeneration. And don't worry, it doesn't mean that it progresses to the worst ones. So these are the little tiny yellow dots which are the drusen. You can just see these little dots there. So what happens in the next stage, a wet macular degeneration? Here you have the choroid, and these new blood vessels, instead of staying where they should stay underneath, they break through like sort of grass sprouting through a broken asphalt. So they break through and grow into the area where the photoreceptors are. And they shouldn't be there, and they cause bleeding, they tear, they bleed, they cause swelling, and therefore, with the swelling and the bleeding, they cause reduction of the eyesight. And that's how it looks in the eye. That's the central area, and instead of looking nice and sort of flat and smooth, it looks like this with lumpy, bleeding, and elevation. So, how do we diagnose it? Well, central distortions. It affects the center, so therefore distortions in the center. That's how you diagnose it. So if you look at a door frame or at a window frame with the one eye which is affected, the center will be sort of distorted. It's named as well metamorphopsia. You might have heard that word as well. It causes reduced vision, reduced color vision, and of course the blockage in the center. So I just have a couple of pictures. This is a distant vision. It's actually already a blurry photograph, but I couldn't find a better one. And I have that for a long time, but it's just a simulation. So have a look at the columns. Can you see the columns here? They get wavy. That's your first step. These distortions, metamorphopsia, wavy lines. And the next step is, not only does it get wavy, it gets a bit blurry as well. And if you have a more severe, with lots of bleeding there and lots of distortion, the center is gone as well. Yeah, so that is the sort of your scotoma. So, macular degeneration is a nasty disease. Only arthritis and heart disease rank above age-related macular degeneration as a cause of impaired function in people over 50. When you ask people, they are devastated with that. Half of the older people admitted to hospitals after falls have impaired vision, and a lot of it is macular degeneration. And it doubles the risk of depression, and it's the leading cause of severe vision loss in people over 50. Late-stage macular degeneration rate is 2.4% of the adult population in the UK. That's quite a large number, and it's rising. Now, how do we diagnose it? Visual acuity, that's a vision chart. Then we do optical coherence tomography. That's a great word. It's actually an ultrasound of your retinal layer in the back of the eye, and we can see if there is any thickening, how much thickening. Then we examine you on the slit lamp. This is just this here. And then we do a fundus fluorescein angiography. Literally, we inject a colored dye into your arm, travels into your eye, and we can see how large the area affected from the new vessels is. So that's really what we are doing with the fluorescein. Treatment. Well, that's the good news. In the past, first of all, treatment of the dry macular degeneration, that's not so good news yet. There is no treatment available. But as you remember, the dry macular degeneration counts for a lot of patients, but it does not cause so much the problem with this reduced sight. A lot of people have still a very good vision with dry macular degeneration. There's some evidence that dietary supplements containing high levels of antioxidants and zinc can delay the progression, but the evidence is not that great. So generally when patients ask me, shall I take these expensive formulas, shall I buy them because they are not on the NHS, I say, well, if money is no option or no issue really, and you want to do something, you can try them, but it's not that much of the evidence. It's more than to have a healthy lifestyle, like, lots of fresh air, healthy vegetables, and no smoking. Smoking is the worst risk factor for it. So that you have more benefit with that as if you spend a lot of money on the formularies. Now, what can we do for the wet AMD? 3-4 years ago, I would have said there's not much we can do, but that has changed. We have now a type of injection into the eye which actually reduces those creeping up blood vessels. It just shrinks them and coagulates them, and that is named the Anti-Vtf treatment. It's ranibizumab or Lucentis. So it's an antibody against those VEGF factors, and it is recommended by NICE for treatment for wet AMD. So it is available as a treatment, a standard treatment in the NHS. So what do we do with that? This is the eye, and what we have to do is every 4 weeks we have to inject a tiny amount of this anti-VEGF drug into the eye, which then distributes and attacks those clumps of new blood vessels and makes them shrink. That's really what it is about. Drawback is every month, the first year, 8 to 10 injections. We do it first every month, and then we sort of expand the time a little bit. But it can be that you have to go for 2, 3, 4 years every month into the eye clinic, which is a huge amount of time and costs and all these things involved. There is another one, which is a new one, and that one, they say, needs only every other month an injection, which would be already something. But it still is quite a drawback with it. So just a summary about the AMD. What is AMD? We know now it's a degenerative disease, 2 forms, wet and dry. Dry, more common, less damage. Wet, less common, but much more damage. Recognize the symptoms. Metamorphopsia, meaning distortions of the line, loss of central vision. And what are the treatment options for the wet form? Anti-Vtf injections, possibly some steroid implants, and very rarely laser. So I have a couple of questions before we come to the last part. Anybody, anything? Yes?
Yes, I've read on the internet, which I know is a dangerous thing, but...
no, it's not. It's not.
UCLA, there's a professor there who is using stem cell to cure AMD, the dry type.
Yes.
And it's going through clinical trials this year, and
yes.
It will be in operation next year.
Yes, there is a lot of research in the moment going on about AMD. There is the stem cell ones, there is as well systemic medication ones, there is radiation, which should reduce it as well. There was in the past as well, in Moorfields, they have done a very interesting operation where they have done a translocation, where they took the retina, loosened it, and turned it around, and put it on a fresh patch as well. So there were all kinds of stuff yet. What I would say is nothing is so clearly ready. So the stem cell, there is some hope there, but I see it still to be quite a few years away for the use in large amount of patients. So in the moment right now, we still really have just the anti-VEGF injections.
Is there anywhere else in the world that's ahead of the UK?
No. The UK is really in the same level than any other country with the anti-VEGF injection. In fact, here we have the Lucentis has gone all through nice. In America, a lot of insurances don't pay for the official brand. You have to have the other brand, which is the Avastin.
Thank you.
Okay.
So retina pigmentaria is something totally different?
Sorry?
Retina pigmentaria?
The retinal pigment area is one of the layers which is part of the layers. So this is the layer between the choroid, the vascular layer, and between your little photoreceptors is the retinal pigment epithelium. And that is as well affected from the macular degeneration because these drusen are in that area and they are blocking that area and damaging that area. The retinal pigment epithelium is as well your garbage collector. It cleans the photoreceptors. So if that gets damaged, it's part of the whole sort of process of macular degeneration. Yes?
I come to the Royal Free for my heart and Moorfields for my eyes, so don't worry about answering the question. Two questions. One, do any cardiac drugs affect the eyes in terms of wet macular-related degeneration, for example, amiodarone or warfarin?
No. There is an interesting thing there. Amiodarone affects your cornea, can affect the cornea with changes, but not the retina. As regards to blood thinning medication, yes, when you have a thinned blood and you have already these new blood vessels creeping up, you might get easier bleeding. And there has been a bit of scare as well with aspirin, low-dose aspirin treatment, that actually can progress the wet macular degeneration. So in patients who are on aspirin, low-dose aspirin, and really don't have to be on it, and have wet AMD, wet age-related macular degeneration, it might be worthwhile considering to stop the aspirin.
And the second question was, when the testing is done, I mean, I go through those 4 stages. Yes. Always with the dye, obviously.
Yes.
I found that I may be having great difficulty reading, but the test at a distance or a few meters, yes, I can still read quite a long way down, which affects under the NICE guidelines whether I get Lucentis. But if I get Lucentis, I know it makes it better or stabilizes the...
Yes, I mean, there's always some patients who will a bit fall below because the guidelines are 6/12 vision for the NICE treatment and some changes in your nerve fiber layer. And yes, I understand there are some patients fall through, and I think we should have a little bit more flexibility there. But at the moment, we are sort of a bit tied down with those guidelines on the NHS. That's correct.
Thank you, that's explained it.
One more question, yeah?
Would blockages in the retinal arteries predispose somebody to any of your 3, glaucoma, AMD, or cataract?
No, blockages in the retinal arteries are a spectrum which I haven't covered tonight. These are all the vascular occlusions where you have the veins affected and the arteries affected. There are then, those have general risk factors like hypertension again, diabetes again can cause all these vein occlusion, but it would not cause AMD as such, and it's not known that it would affect the glaucoma, although some glaucoma might be predisposed if you have a very low blood pressure and a low perfusion rate of the eye, you might be at a higher risk of glaucoma.
There were
One
a
more?
couple more.
Yes. Yes, please.
I've had a diagnosis of AMD a couple of years ago, but I don't have any symptoms.
Right.
Will it necessarily progress to the last stage?
No, absolutely not.
No?
No. How long would it take? No, it doesn't progress. So if you have the dry age-related macular degeneration, which are just those drusen there, we have patients who have those for 20, 30, 40 years, they never progress, okay? So it just means that if you know that you have these changes there, that you watch out, and that from time to time you look with one eye and with the other eye at a door frame and just check, or at a chart, an answer chart, and see if there are any distortions. And if there are any acute changes, then you have to see somebody quite quickly, and it should be within 2 to 3 weeks of an acute change. You should be seen by an ophthalmologist.
Is that with any waving?
Only if they change. If you have drusen and you have already some changes and they have been checked and they have not changed any further, that's fine. But if you get new changes, that's it.
Another one at the back.
Okay?
I haven't covered this, but what are floaters?
Oh, floaters is just little bits and pieces of debris in the gel in your eye. You know when you saw the picture, you have the front part, the back part, and there's this big space in the middle. That's actually filled with vitreous, which is a gel kind formation. And during your lifetime, all the little bits and pieces of debris collect in there, and they swim around in there, and they are the floaters. And as well, the jelly withdraws from the back and from the optic nerve and lumps a bit more together, so you get then these funny kind of sometimes circle or semicircles or worm-like lesions. So this is just debris in the gel. Last question.
Some high street optometrists, including ours, offer a preventative scan picture
Yes.
of the macula. I've heard people say, oh, that's just a way of optometrists making money. But I thought, well, if you have that every 2 or 3 years or whatever, it's a small private expense. Then if nothing else, there's a baseline if something else starts, and an early warning if you're moving that direction. What do you think? Is that too much information?
That's a difficult question. I don't know if there's any optometrists in the room. I think if you have a scan and a photograph, yes, it would give you some information, but I don't think it would, I would not recommend it as a sort of a thing if you have no other problems. Of course, all the people we come to the diabetic retinopathy in the moment, they all get photographs in anyway. So if you are a diabetic patient and get your yearly screening photograph, you certainly should not go to the optician and have another photograph done, because that would not be of any benefit at all. If you don't have normally photographs done and you are quite, interested as well, how does my macula look? Why not? But I would not take out my last penny to go for it, because I don't think it would give that much more of information. I hope it answered it all right. Okay, so shall I go to the last part? And then I think we can finish in time. So, diabetic retinopathy. What is diabetes and diabetic retinopathy, and who is at risk? What is screening? What are the symptoms? What is the clinical finding? And the treatment. So, diabetes, you might probably all of you know, high blood sugar levels, lack of insulin, type 1 diabetic, a reduced efficacy of insulin, type 2. Diabetes can affect lots of different parts in your body, the eyes, your heart, the kidneys, and your nerves. So in 2011, that's the only picture with statistics, so don't worry. In 2011, the prevalence of diabetes in the adult population in the UK was 4.5%. In England, it was 5.5%. In 2011, 2.9 million diabetic patients we had in the UK, but by 2025, we expect to reach 5 million diabetics in the UK. So it's really an endemic. We have a large increase of the diabetic population. Type 1, very quickly, the insulin-producing cells in the body have been destroyed. It's often in younger patients. The body is unable to produce insulin, and what happens then is it accounts about for 10% of patients, of people with diabetes. You need injections, diabetic insulin injections, to counteract the loss of your insulin. Type 2 is the more common one. Two main reasons: reduced production of insulin, but as well insulin resistance. Who develops type 2? Well, generally Caucasian people over the age of 40 are more at risk. But in the South Asian, African, Caribbean background, we find that type 2 already in the age of 25 plus. Treatment is diet, physical activity, oral medication, and later on you will probably need as well insulin. So risk factors for diabetic retinopathy, because we said diabetes affects your eye, and that's all what I'm talking about now. The duration of a diabetes affects the diabetic retinopathy. The metabolic control. The better your diabetes is controlled, the less likely you are running into trouble with your eyes. And as well, blood pressure is an additional risk factor. It doesn't add to it, it multiplies the risk of diabetic eye changes. So, what is diabetic retinopathy and screening? Well, we have a stand tonight there. We have two stands. We have the RNIB stand and we have the diabetic eye screening program. So the screening is there to detect and treat sight-threatening diabetic retinopathy before the vision is lost. All right, so if you screen early, if you find the problems, you can treat it. If you come too late, there's nothing one can do. Now, the National Health System has the Diabetic Eye Screening Program. It's a national diabetics program which is for all patients with diabetes over the age of 12 years will be invited for yearly digital fundus photography. So anybody being diabetic, you should have once a year your photographs taken. The North Central London Diabetic Eye Screening Program has been newly formed in 2012 in July, amalgamated from several programs, and it's the containing Barnet, Camden and Islington and Enfield and Haringey. We are a huge program. We are the third largest one in England. And 13 different screening sites are available, and on our desk in the back we have a poster, and on the back you can see all the different screening sites. Patients can go to any of those locations. They can choose. And as I said already, the information stand at the meeting, and the only thing is the service is no longer available through optometrists. So if we have a look at our two boys, this is what you have if you have advanced diabetic retinopathy. And yes, there you have dark patches, okay? In diabetic retinopathy, because of the bleeding in the front part, you can get dark patches. It affects your small blood vessels, and it leads to occlusions and bleeding. So just a drawing. What happens? Can you see these little red dots? These are your little bleedings. Larger blots, larger hemorrhages, flame-shaped hemorrhages. Yellow dots are little exudates, blood vessels who are leak. White spots, cotton wool spots. This is a picture of a patient, and that's the central part, the macular area here, and you can see these bleedings there and the yellow dots, which are the exudates. So this patient is having some diabetic changes there, and probably from this area here, the swelling is causing slowly a decline of the central part of the vision because it causes swelling here. What is the more severe stage? Stage 2. We have funny blood vessels, we have funny loops, we have more bleeding, more cotton wool spots, and funny little sort of blood vessels to wiggle around. And in the proliferative one, which is the worst one, there you can go blind quite quickly. You get new blood vessels at your optic disc, and you get an swelling in the periphery. You think, new blood vessels is actually a good thing, isn't it? I mean, the eye has not enough oxygen because the capillaries are damaged, so the eye creates new blood vessels. So why not? But it's bad because these are new blood vessels which are not your normal anatomical structure. So they are much more fragile. They don't have the right anatomical protection of the walls. So they leak, they break, you cough, you lift up something heavy, these blood vessels crack and they bleed the eye full, and that happens here, and then you can't see, yeah, the eye is full. And then it causes a reaction in the eye where the nerve fibers
draw together and you get a detachment of the retina and then blindness. So I said that, lack of oxygen, and you can get
fibroscar tissue, and you can get bleeding and detachment. Now, this is like a picture, and what we do is treatment-wise. If we have new blood vessels, we put in lots of laser. We destroy the periphery of the retina because you don't need that so much, the periphery. You need the central part. So we destroy the periphery to channel the oxygen which is there to the center so that we can maintain the center. That's what it really is about. Again, here come again anti-Vtf injections, new treatment for diabetic macular edema, just been sort of NICE approved, not gone entirely through the PCTs yet, but I hope that by sort of June, July, we should be able to give these injections on the NHS. And one can give as well some steroid injections, and if everything goes wrong, one can suck out the blood with an operation, which is named a vitrectomy. So the laser treatment here, all these tiny little dots there is laser. This is a fluorescein, and you can see like sort of these fan-shaped things. These are all new blood vessels which are leaking. Complications of the diabetic proliferative disease, can you see, it's not only that these new blood vessels grow in the back of your eye, they grow as well on the iris in the front part, and they obstruct your angle, and that's one of the reasons why you can get secondary glaucoma with diabetes, because it blocks it. And the diabetic macular edema, I spoke to you about it, it's right there, these exudates there, and it affects the central part. And that's a nasty one, because till now, we didn't have much treatment possibilities, because the only thing we had was laser. And laser treatment in the center did not really improve the vision, it just maintained it. But now with the new anti-Vtf injections, we have hope that we can sort of maintain for more patients the sight. And as you can see, this is a macular edema caused by diabetes. All these cystic spaces here, it should look like here. This is an OCT, so you have these cysts there everywhere, fluid there. Then you get an anti-Vtf injection, and then it looks back to normal like it should look. The problem is it doesn't stay long. It comes back again, like with the macular degeneration. So you have to have these injections quite frequently. Causes of blindness is advanced disease, retinal detachment, which I explained to you, the glaucoma with these new blood vessels on the iris, the hemorrhages, and the maculopathy. Okay, I think that's a summary now of my talk tonight. Summary, main causes for visual problems in adults: glaucoma, cataract, age-related macular degeneration, and diabetic retinopathy. Cataract can be operated and sight can be restored. That's good. But glaucoma, AMD, and diabetic retinopathy are the major causes for permanent vision loss in the adult population. But if treated early, all of those will not lead to blindness. And these are my boys here again: glaucoma with cataract, the blurred vision, with macular degeneration, the black patches with diabetic retinopathy. Thank you very much. As promised, I think we have another few minutes for questions.
Anybody with any questions for Suzanne?
Yes, thank you.
Could you possibly discuss with us the Charles-Bonnet syndrome, please?
Yes. Charles-Bonnet syndrome is a very interesting syndrome. It is in patients who have, in both eyes, quite a reduced eyesight. The eyesight should be 6/36 or even worse. It's often in patients with severe macular degeneration or other degenerative disease. And what happens is the brain, we think, this is how it happens, the brain doesn't get any stimulation from the visual cortex anymore because nothing comes there, no proper picture. So the brain makes pictures up. And it makes these pictures up in the most amazing way. Sometimes you see defined geometric patterns like carpets patterns, or you can see people, you can see distinct people, and you can see exactly and clearly those people there with the colors and perfect vision. The difference is between an illusion and the Charles-Bonnet is that you as a patient know that these things are not really there, but your brain is making them up. You know that. But when you have a sort of, when it is a sort of more like a cortical disease, you don't know if it is an illusion. You believe it's there. But Charles Bonnet, generally the patient knows that this is not there. But it is very frightening if you see it the first time, because people think they are going mad. And of course they are not. It's the brain making up for having no visual input. Did that sort of explain it a bit?
Yes, because my sister-in-law suffers with this, and it's scary. It really is.
It is very scary, and people are very concerned they go mad. And when I have patients like that, I take time and I explain to them, look, it is an annoying thing, but just try to see it as something positive, live with it, and it's nothing negative, and you are not going mad. Welcome.
Yes. Just going back to the slide you had, and the little boys were running into the road.
Yes.
Which worried me, because I wonder if glaucoma patients tend to have more road accidents than the general population.
They were looking at it, and as far as I'm aware, there is not much going on. I don't know exact statistics, but maybe because when glaucoma patients are detected, they all have to go for their visual field test. So everybody who has been diagnosed with glaucoma gets invited from the DVLA to attend an optician or an ophthalmology clinic for a visual field test. And it's a vigorous test with both eyes open, but it looks exactly at those areas in the periphery and checks it. And then very, very soul destroying sometimes if you have patients who say, I see perfectly, and they don't let me drive anymore because they don't realize the damage there. And it is really bad, but it's very strict. So yes, there is field tests because of that.
Can I ask you about flashing lights? Both my wife and I suffer from episodes of flashing lights which occur without any headache at all. No migraine, neither of us have migraine, but we both have these episodes of flashing lights.
Okay.
Take generally between 10, 20, 30 minutes to go. My wife tends to take paracetamol, lie down. I don't take anything, I just sit quietly and it goes. And there's no particular after effect. Now,
there's an interesting thing. Yes, please. Sorry.
I understand this is some sort of interference with the visual cortex. Both my doctor and optician say, don't worry, there's nothing to worry about, we can't do anything about it anyway.
Okay. Well, yes, it's interesting the time span you gave me there. Flashing lights is quite a common thing. You have these very short flashes of light, which are just seconds, which are normally caused by the vitreous pulling on your nerve fibers. They are different. If you have flashing lights for about 20 to 30 minutes, and often they come in the periphery, and they are more like zigzagging lines, that is more in context of an ophthalmic type of migraine, especially if it takes 20 to 30 minutes, and you don't need to have a headache with it. And so if it is in a time frame of 20 to 30 minutes, starts in the periphery, often gets slightly larger, and then reduces again in size, then the diagnosis of ophthalmic migraine is generally made. And you would not find anything on CT scans or anything like that. Any tests would not show you anything. It is really a diagnosis of the clinical history, how long you have these flashing lights, and exactly how the symptoms are. And as I said, the shorter ones, if you have flashing lights, just like a little bit in the periphery and goes on and off, then generally I say the patient should be checked in the clinic to make sure there is no hole or tear in the periphery of the nerve fiber layer where it has pulled, just to exclude that. Because if there is a small hole or tear and one finds it early, one can just put a little ring of laser around and it will not lead to a nerve fiber detachment. But 20 to 30 minutes, I would agree with your GP and optician that it looks more like a vascular event in the cortical matter.
If the visual cortex causes these kind of illusions of grids, can anything be done about it?
Well,
I know someone who had one, it lasted about 10 minutes. One episode sort of was like kind of blindness with this sort of coloured grid, and after 10 minutes
well, I'm glad you brought that part up, because I said flashing lights, very short, being of your vitreous changes, 20, 30 minutes being migraine. And the one in the middle, which you just mentioned, sort of 10, 15 minutes, and maybe with darkness, and then slowly the vision coming back, would count for a TIA, trans-ischemic attack. And that is something where one has to look again, like more in a stroke kind of picture, and do some investigations, do a carotid Doppler and investigate. Yeah? Yes?
How do childhood illnesses such as measles or encephalitis and so on affect eyesight? How can they?
I think in the past, where there was no treatment, antiviral treatment, measles could cause corneal scarring and then affect it quite a bit. And they can cause as well an optic neuropathy. They can damage the optic nerve. Nowadays, if you have measles, you can get more earlier treatment, and it's not as likely as in the past.
Why does uveitis occur?
Sorry?
Why does the condition uveitis?
Okay. Uveitis is a disease where it is an inflammation of your blood supplied layer in the eye. So layers like containing the blood supply, which is the iris, and as well in the back of the eye, the uvea, which is the choroidal layer underneath. So all these layers can be affected and can be inflamed, and that is named uveitis. And then you have the anterior one, the front part one, meaning the iritis, where the iris is inflamed, and you can get the posterior one, where you have in the retina changes of that. So it is an inflammatory disease, more common in patients maybe with systemic diseases like sarcoidosis or rheumatoid arthritis. In that kind of group, you will find that more frequently. Yes?
Talking about AMD, as I understand it, the retina is a fairly small, rather curved thing.
Yes.
With, packed randomly with receptors.
Yes.
And in fact, it's not like a television camera at all with a regular grid of pixels or anything. And that in fact, the reason we see straight lines, graph paper, columns you had, is actually a very early learning process in the brain, if I understand it, from childhood.
To some extent, yes. But what happens is the brain gets very early adjusted to that. And although it's slightly curved, it would not be distorted. The actual area where we have those distortions is very small, is just about 1,500 microns, so 1.5 millimeter is all what it is, your macular area. And even the center, the fovea, is even smaller than that. It's just about 100 microns. So it's a very tiny area we are looking at, which gives you that definition. So the reason why these things are distorted is not so much that we go back sort of to congenital type or before birth. It's more like it is affecting just the center. That's why.
The other question I had earlier was, in cataracts, you're replacing the lens in the original sac.
Yes.
Material. Now, presumably the ciliary muscles are still there.
Yes.
Do you see any chance at any time that they would be able to use a fluid?
Yes, there is lots of research about that. That's a very good point. The idea is to take out the cloudy lens and fill up the back, fuse it, close it again, and there have been a couple of test operations in that. And then the thought is, if we fill up that space again and the ciliary muscle is still intact, we would still have our accommodation, because that is what we all really would like to get back, to be able to read here, here, and here, and not having these varifocals and glasses or multifocal lenses which are not good enough. So they are working on that. In the moment, they have experimented with some of them. It's not at the level where we can start off with, but it is in working. So maybe in 5 or 10 years, one can do that.
Just one last question. 1967, Christian Barnard did the first heart transplant. Is there any movement on eye transplant?
Well, I would not be the right person to ask of that. I just know sort of what I have in research, but it is very complex, because the reason why is because you have your optic nerve with millions and millions of connections, because you have millions of nerve fibers and they connect out there, and that would be the problem. Now, you have some artificial eye ideas where they start to put now little microchips in to the back, implanted into the retina, and then you can they connect it to the brain and stimulate cortex with it, and then you can try to learn. And there are some cases of retinitis pigmentosa patients who are blind and can't see anything, where they are able then with these microchip implants to see 4 forms and shapes again. So I'm sure there will be lots of development, and it has improved huge amounts. We are still very far away from it. I don't think though a transplant of the whole eye would work. It would be more like sort of microchip or sort of electronic. It would be more like a sort of a bionic sort of kind of eye.
Thank you.
Welcome. Okay.